Good morning, everyone. Hope you're having a great day out there. And I wanted to cover a topic that was requested of me this morning. Actually, in the wee hours of the morning, I got a call from a MoveNow doctor who I've gotten to know quite a bit over the last couple of years, and he is venturing into doing more corrective work in his clinic, and he had a question for me. He said, what should I expect? How do I frame this for the patient? What's going to happen in 12 weeks when we do comparative x-rays, and what types of things should I anticipate seeing? And it brought back the memories of the first time that I started doing curve correction, and I was having patients go through postural corrective exercise and traction and all this stuff, and I didn't know what to expect myself, and I was like waiting in anticipation. I was just as excited as the patient was to see what was going to happen. And so it's tough to really like prepare a patient for what to expect when you've never seen it yourself quite yet. And the powers that be, the different groups that I was training with and learning from, didn't really give me a clear expectation of what to see, or maybe I just didn't ask, or maybe I wasn't that far along. I don't know, but I didn't really know what to expect, other than I knew they had some abnormal structural stuff going on. I was aiming to change it, and it was like the moment of truth when you take a comparative x-ray. And so now here's some things to just cover first off. Well, first off, I put a link up above. It's demo.movenowu.com if you want to watch a 30-minute behind the scenes, not really demo, well, yeah, I guess demo of inside the doctor training portal that now we have over 130 doctors who are part of this program, have access to this, and are implementing pieces and pieces and pieces. And we're trying to help them implement more and more of this in their clinic, because as you implement more, life is easier, things go smoother. Questions like this one right now, as far as like, what exactly is the patient going to expect? And like the exact question he asked me actually was, okay, so am I going to have a patient go through all this, and then like in 12 weeks, I'm just going to have to tell them nothing changed and it's time to go and do another 12 weeks? And I said, that's a great question. And then I actually pulled up and showed him inside of our doctor portal a whole new lesson that we just added, because there's 32 videos that we added in the last 2 weeks, because we're covering some pretty important things that we've just never dove into before. And it's in a section called the schedule. And in the schedule, we talk about how to map out the schedule, how that's going to work. And then I tied that back into answering his question. But anyway, his exact question was, what exactly is going to help you set up this anticipation for the patient? And I said, that's day 5. What do you do in day 5? Day 5 is goals. Goals is where you set goals with the patient. You set clinical goals. And this is a topic right now that we cover in detail in multiple different lessons, because it's not just a one-hit wonder. It's not just a quick answer to really dive into it, but to step back and give you the global answer of the truth about corrective care in chiropractic is that your patient is a living, breathing human being. There are multiple variables that affect their overall health and their spinal health. If we're looking to improve their spinal health, you have to address segment, posture, and movement. Segmentally, you have your specific detection and correction of subluxation in the spine. Okay, there's different methods out there that people do. As everyone probably knows, because I put this influence in there all the time, I'm not bashful about it. I do Gonstead, and I feel like having a very specific, methodical approach of finding and fixing the segments of the spine is important. Doesn't mean you have to do Gonstead. We have other doctors that are part of this group that are amazing chiropractors that do upper cervical work, or they follow other systems and techniques, but it's not just hit them high, hit them low, roll them twice, let them go type thing. I'm not a huge fan of that. I do think specificity matters. And we see it on a daily basis with patients who have gone elsewhere, and they get the $1 million roll and pop and pray type of adjustment, and they don't do any better. And then we give them a proper adjustment and they get better. And that's before they even start the corrective care portion, but that's what at least gets their attention so that they're ready to listen. Because let's face it, the majority of patients come in and see us because they have a symptom, they have pain, they have something going on initially, And then it's our job to really find what they want, educate them, coach them, and teach them about the benefits of real corrective care. Now, in doing so, there's a saying that I've said before is don't put all your clinical eggs in one basket, meaning if you're really adamant about curve correction, you just started getting into curve correction, you want to change someone's lumbar curve and cervical curve and thoracic curve and put it within normal limits so that they have good structural integrity, guess what? Some people are going to move at different rates. We have some patients that go through 12 weeks of corrective care and their spine barely budges because either they're very rigid, they have decreased disc height, maybe like a D4, D5 discs, which is a Gonstead nomenclature as far as grading a disc. D is degeneration. It goes from D1 to D6. D6 is bone-on-bone fusion. D1 is a swollen disc in the acute early phase of this. So basically, if someone has a thinner disc, if they're more rigid and they have major functional issues that you'll detect on your MoveWell 3, which is our detailed level 1, level 2, and then even level 3 in some cases, movement screening and assessment, based on their scores and based on what's going on with them. And once you start understanding movement and looking at movement and then pairing that back to posture and what you see on exam findings, it starts to make sense and you can start to set realistic goals for your patients. Don't put all your clinical eggs in one basket saying that everything sits on having a change in their curve. Yes, it's important to change their curve. However, there are patients we see where we maybe change a kyphotic thoracic curve that's 70 degrees. Maybe we change it to 65 degrees in 12 weeks. However, their functional movement has improved. Segmentally, they're adjusting much better. From a standpoint of activities of daily living, they're able to do multiple things that they weren't able to do for the last 20 years. Do you think that person sees that as a failure when they have a 5-degree curve change? Should you as the doctor see that as a failure? My answer is a resounding no. That's not a failure. It could be that those first 12 weeks is conditioning. That could be the conditioning process of all that person can tolerate as far as thoracic spine extension under load, which is traction. Maybe that person wasn't great at following their home care. It took them that long to start to develop habits, but maybe week 9 of the process, they really started to get in the groove and they understand that they could have done better and now they're ready to do better because they're motivated by all the other markers that have changed, maybe more so than their curve. So, all in all, there's multiple variables that we've learned over the years as far as giving us as the practitioner a better anticipation of what is going to likely change and what it's going to take from the patient and what it's going to take from goals and progress in office to really see the change that you as the provider want to see or that the patient wants to see. So these are things that we've learned over the years so we can set up the patient for a realistic expectation. So the truth about corrective care is really this. A lot of doctors that I've seen that are getting into it go to a seminar or they study a certain technique system and they think that is the comprehensive truth of everything. And then they find out clinically there's other variables. And they find out some patients really respond really well, but some patients don't. And they don't get these corrective changes that they're laying everything on the line and saying that's all that matters. And then what happens is the patient gets to that point where you're doing all the comparatives and there's not a whole lot of measurable change and they say, I just wasted all my time. It didn't work. When in reality, that was one variable of many. Is it important? Yes. But is it going to change the same for every single person? No. And there's many variables, and I covered some of them in this discussion. Those variables are patient's age, their level of functional movement capacity as far as what's going on that you see on their movement assessment, their disc quality, their presence or absence of pain initially, how acute they were, how active they are across the board, and then just how engaged they are at following your recommendations and going through their home care. Okay, now with that said, there's patients that we have that started a 75-degree thoracic curve, and 12 weeks later we take comparative x-rays and they have a 50-degree thoracic curve, which ideal normal is 44 degrees plus or minus maybe 8-10 degrees. So that's pretty good. That's really good. We have a good fair share of patients that have these massive changes. We see it pretty much every week in practice. All right. We have some patients that make moderate changes in their curve correction, and they might admit that they weren't as adamant about following all the recommendations. However, maybe they're following the functional movement component more. Like, that's what they've gravitated more towards. They don't like doing the traction part as much at home, or they just haven't put the time or energy into it like maybe they should have. And their movement improves and they're feeling better, and now they're getting into fitness and exercising like they hadn't for the past 20 years. And then we have some patients that they come in so acute, and maybe throughout the process they have a flare-up, they have an injury, they have something, they make very minimal changes, but everything is changing just a little bit across the board. Maybe a little improvement in posture, a little improvement in movement, starting to develop some habits. They know that they can be doing more on their own as well, and they appreciate the fact that they have a system that they can follow, but their pace requires that they move a little bit slower. So that's how we take someone through the initial phase of corrective care. And again, the truth about corrective care with the world, according to me, I guess, is that there's multiple variables in there. It's not just, you can't just be a one-trick pony. And I think that these technique systems out here that teach it like that or preach it like that mislead chiropractors a bit, and then the chiropractor figures that out in practice. And so it's important as a doctor to understand that there's just many facets and variables that go into someone's overall corrective changes. What is corrective care exactly? There's some chiropractors in the past that I've heard that think corrective care is see someone 3 times a week for 6 months and adjust their spine 1,000,000 times, and that's corrective care with no other guidance, no other integration of anything. I don't think that's corrective care. I mean, I'll be as bold as to say that's not corrective care. That's just over-adjusting someone. Then you have other people that just focus on posture. You have others that just focus on movement, but they don't do anything with posture, and the patient has a rigid thoracic hyperkyphosis, and you're trying to teach them mobility and stability exercises, and the person can't even move. You're not going to get very far with them. And then you have like other professions, like physical therapists and personal trainers and different exercise people that are anti-X-ray, and they don't take X-ray, and they have no idea what the joint quality of the patient looks like. So it's like all these different people have their lens that they look at things through, and it's great that they're passionate about it, but when you got your blinders on, you start to miss some of these other things out there, and you're fitting the patient into your paradigm when there's other variables. And so it took me several years in practice to come to that reality, and I would say mature enough clinically that I wasn't so attached to one technique or one system that I could be intellectually honest with myself and my patients and say, there's more stuff out there. And what that requires from me now as the practitioner, and what it requires from you as the practitioner watching this, is that if you really want to have that clinical excellence, you have to learn more. You have to dive deeper. And it's not like, well, I went to a bunch of seminars and got certified in this technique. I'm done now. Now just rinse and repeat for the rest of my time in practice. No, it's a constant learning process. All right, constant learning process, ongoing. It never ends. It ends when you die. It ends when you're done in practice. Okay, but that's the truth about corrective care, according to me. Take it for what it's worth. Hope that helps. If you want to learn more about the systems that we've put together that cover every single thing from A to Z, like you could literally build a practice straight out of school following all these systems, or you could be a seasoned chiropractor in practice 20 years wanting to have better systems. We have a mix of both. Go to demo.movenowu.com and check that out, and then you can jump on a call with our support after that and ask questions and see if If you think and we think that this is a good match, in some cases it's not. In more cases than not, it is, if that makes sense. So with that said, have a great day. I got to jump on a pre-shift huddle with my team. I'm almost to the clinic. Over and out.